Hello, everyone. Welcome back. Hope everyone had a great lunch. Thank you so much for joining us. We're so excited about our afternoon today. I would like to welcome Dr. Ron Cohen, who will be kicking us off for our afternoon sessions. Dr. Cohen, off to you.
Welcome back, everybody. It's great to, in air quotes, see a bunch of old friends and a bunch of new ones in the audience. This afternoon, we're going to start off with Dr. Anna Liu, who is a board-certified allergy, immunology, and infectious disease physician with over 20 years of experience. She's the clinical associate professor at the Stanford School of Medicine in both pediatrics and medicine, and currently teaches in our spectacular Foundations of Clinical Medicine course. Her research interests include optimizing care for patients with antibiotic allergies, and she has authored close to 50 publications in the field. She has been recognized for her work by the American Academy of Asthma, Allergy, and Immunology, the American Medical Women's Association, and the NIH. And I look forward to that fascinating session. And so with that introduction, I think I will hand the baton over to Savannah and Dr. Liu.
Thanks, Dr. Cohen, for that really kind introduction. It is, when you said 20 years, I was doing the math and thought, oh, he's right, which is kind of scary. So just want to make sure everybody you can hear me okay? With a thumbs up? Okay.
Yes, we can.
So, Savannah, thanks for handling the slides. Good afternoon, everybody. Hope you all had a great lunch and had a chance to stretch and maybe even be outdoors and look at some trees far away. It is my pleasure this afternoon, and thank you to the conference organizers for inviting me to speak about drug allergies in pregnancy, and as well as a sprinkling of other general allergy topics. My disclosures only are that I serve on an advisory board for farming on the diagnosis of primary immunodeficiency, so it is not relevant to today's discussion. Oh, I'm sorry. Next slide, please. Yeah, thank you. So our objectives are to describe the impact of medication allergies in pregnancy, to discuss the safety of delabeling penicillin allergy in pregnancy, to describe common allergy concerns and their treatments in pregnancy, and to discuss the role of maternal diet in pregnancy and nursing in infant food allergy. Next slide, please. This is an outline of where we are going for the next 45 minutes. We will talk about mostly drug allergy. About 60% of this will be drug allergy, and that's because this is a topic that I think that a lot of people don't have familiarity with outside of the allergy field, whereas I think a lot of you probably already have some general knowledge about allergy, anaphylaxis, asthma, allergic rhinitis, and atopic dermatitis, and food allergy in pregnancy, but we will cover some of that as well. Next slide, please. So this is an overview, a schematic of the drug allergy program and the different areas that we collaborate with our referring physicians on and referring healthcare providers on. And so antibiotics are the bulk of what we do, but there's also a very substantial portion of what we do is on chemotherapy and biologics. And so aspirin and NSAIDs is also a large area. We actually have a full clinic devoted to just that. And perioperative anaphylaxis, progesterone allergy, which is something that is relevant to this crowd, iron allergy, and vaccine allergy. Antibiotic allergy is the one that touches on the most different groups the most often. And there's a lot of data now on why it should be an institutional priority, how it affects not only individual health outcomes and health management, but also institutionally how it affects drug resistance and cost and readmissions. All of these require collaboration across multiple services beyond allergy, and that's actually one of the things that I really like about it. Next slide, please. So drug allergies are a space that many providers don't feel that equipped to deal with, and we've done a couple different survey studies on how non-allergist providers deal with drug allergies. And the bottom line is that even groups that have high confidence in their knowledge about drug allergy do not feel equipped and do not really want to be the ones doing the procedures that would allow patients to be delabeled of their drug allergies. So there is a lot of discomfort when it comes to actually giving the medication, even if there is a lot of knowledge about whether it would be safe. And we now understand, and avoidance is usually recommended out of an abundance of caution. And it's very well intentioned, but now we understand better the impact of unnecessary avoidance. There's a lot of costs to the individual person, to the institution, to the healthcare system. And we'll talk a little bit more about a few different classes of these allergies. Next slide, please. So when it comes to approaching drug allergies, this encompasses a range of adverse drug reactions, but when an allergist talks about drug allergies, we're thinking of something that is specifically immunologically mediated and not necessarily a side effect or a non-allergic adverse effect. Within those that we deal with the most, the more benign reactions, fortunately, tend to also be the ones that are most common. So while the life-threatening reactions are usually pretty uncommon, but it's the uncommon reactions that warrant caution and a more granular understanding of drug allergy. So here on the far left, we have what we would call a morbilliform rash or a drug exanthem, if it's in the context of a drug allergy. And then to the right of that, we have urticaria, what we call hives. And so to a lot of people, any itchy rash is a hive, but to us, a hive is a very specific type of rash. And then on over, we have a patient who has angioedema, and above that is a different kind of morbilliform rash that we would call DRESS, or drug reaction with eosinophilia and systemic symptoms. And then to the right of that, we have a patient who has, or two patients who have SJS and TEN, so Stevens-Johnson syndrome and toxic epidermal necrolysis. And this is a very life-threatening type of reaction. Next slide, please. So to focus on penicillin allergy because of its relevance in maternal health, next slide, please. Let's take a look at a few cases that are somewhat related to each other. This is a 35-year-old who presents for prenatal care at 9 weeks of gestation, reports a history of penicillin allergy, and as a result avoids beta-lactams. So beta-lactams include penicillins, cephalosporins, and carbapenems, as most of you know. And in scenario one, this patient is GBS positive, it's colonized, and during labor, ampicillin is avoided because of this history of penicillin allergy, and clindamycin is given instead. Then the baby has a fever, goes to the neonatal ICU for antibiotics and a sepsis workup. And the relevance of this case is that 10 to 30% of patients, pregnant patients, are colonized with group B strep. And it's associated with neonatal sepsis and meningitis, something that Dr. Gibbs will probably touch on in his talk, as well as with endometritis, sepsis of the pregnant patient, and wound infections in the peripartum period. First line antibiotic is penicillin or ampicillin. But if a penicillin is not given in group B strep, then there's a higher risk of failure from non-penicillin antibiotics with attendant possible increases in neonatal sepsis. And those patients, those infants may need to be in the ICU more often. So group B strep is one of these bugs where beta-lactams are the first and best choice, and that anything outside the beta-lactam class of antibiotic is associated with higher failure rates. Next slide, please. So here's another case, similar case. A 35-year-old presents for prenatal care at 9 weeks of gestation, reports a history of penicillin allergy and avoids beta-lactams, just like our last patient. In this case, the patient has a cesarean delivery, receives vancomycin perioperatively as prophylaxis instead of cefazolin, and has a vancomycin infusion reaction, and later on develops a surgical site infection. So cesarean deliveries occur in about a third of births, as I understand it, and you all may know better. Again, first line is cefazolin for prevention of surgical site infection. Vancomycin, though, has been shown time and time again to be inferior to beta-lactams, like cefazolin, and for susceptible infections. So we use vancomycin when we have to for MRSA, but if we're talking about a patient who is just coming in for a non-MRSA infection, then really cefazolin is the way to go for the most effective surgical prophylaxis, and is also the best tolerated. Vancomycin very commonly causes vancomycin infusion reactions, maybe 30 to 50% of patients. And this is what used to be called red man syndrome, and now we call it vancomycin infusion reactions. And surgical site infections, interestingly, are increased by 50% in patients who have illicit penicillin allergy if they don't receive a beta-lactam like cefazolin. So the institutional and personal costs of avoidance are pretty substantial. Next slide, please. So now a third case, again, 35-year-old presenting for prenatal care at 9 weeks and reports a history of penicillin allergy, avoids beta-lactams. And now in this third scenario, the patient has a UTI during pregnancy, but is avoiding amoxicillin, cephalexin, and because those are both beta-lactams, avoiding ciprofloxacin and trimethoprim sulfamethoxazole in pregnancy, and nitrofurantoin fails, and the culture grows E. coli that's resistant to nitrofurantoin. And now what could have been handled with a simple phone call may need to become a visit, possibly urgent consultation with ID and or allergy. So it is something that really complicates care, when we can't use beta-lactams in pregnancy, both because those are best for the pregnant patient and also because they're safe for the fetus. Next slide, please. So this is from the CDC. About 10% of the population reports a penicillin allergy, but less than 1% of the whole population is truly allergic. And about 80% of patients with an immediate onset penicillin allergy, even anaphylaxis, will lose their allergy after 10 years of avoidance. And there's pretty good data that 5 years is a good cutoff. And so and this is probably some combination of loss over time, along with mislabeling, and along with changes in the manufacturing processes of antibiotics, particularly cephalosporins and penicillins. And so, the likelihood of a current penicillin allergy in kids with a history of an IgE-mediated reaction is probably somewhat higher because it's, they're more likely to have been less than 10 years since their last reaction. But in pregnant patients, we often have a very good chance of being able to delabel them. So, next slide, please. So I keep mentioning this concept of delabeling, and this is the concept of disproving what is a listed drug allergy. And whether it can be done depends on a lot of factors, including the drug class, the history, and testing if available. Next slide, please. So penicillin skin testing and challenge is what we usually offer for patients where there is a concern for or a history of an immediate type reaction to penicillin. Sometimes we do this for delayed reactions, although it's not as predictive for that. This is different also from patch testing for delayed hypersensitivities. And in 95% of patients with negative skin testing are not penicillin allergic. But for that rest of that few percent, we always do a challenge. So the skin test itself takes about 45 to 60 minutes and it's 3 steps, including some intradermals, which are like the old-fashioned PPD TB tests. And so it creates a little bump that lasts about an hour, maybe less than that. The challenge itself is a 2-dose. So we do a test dose followed by a full dose, and that takes about 90 minutes. So this is what we do all the time in our clinic, and many of the OB patients who have been referred to us will have this testing done as part of their evaluation. Next slide, please. So in pregnancy, this is something that has become, we have much more awareness now of the safety of penicillin allergy testing in pregnancy, and as well as the benefits of doing it. This is from JAMA. This has now become industry standard, at least in academic centers, that we do penicillin allergy testing in pregnancy. It used to be thought that if a patient was pregnant, we're not going to do any kind of testing. And in many centers and many allergy clinics, this is still the case, that they don't even do dust mite skin testing, because why would you do that during pregnancy? We consider pregnant patients in a higher risk category. And the Stanford Women's Center, patients presenting for prenatal care are screened during intake for penicillin allergy as part of a collaborative QI project that we have with a number of our OB colleagues. And this was work that was started by two now attendings when they were fellows. One was an allergy fellow, and the other is an MFM fellow. It's Meryl Sperling and Linda Zhu, in collaboration with some of our other OB colleagues, including Dr. Gibbs. And then they're offered, so then these patients are offered a referral to allergy clinic for a telehealth consultation, which may be followed by testing and challenge. And so far, it's been a really wonderful program. We have been able to delabel the penicillin allergy of probably around 95% of the patients who we evaluate. Next slide, please. And this is no longer something that is off the beaten path. Penicillin allergy testing, according to the ACOG Committee on Obstetric Practices from 2020 and 2022 for prevention of group B strep early onset disease in newborns, is safe during pregnancy, and it can be beneficial for all women who report a penicillin allergy. Ascertaining the absence of a type 1 hypersensitivity reaction will eliminate the need to use alternatives to penicillin for group B strep. And you can read the rest of it, but essentially we have the support of ACOG as well as multiple allergy groups and the ID Society of America and the CDC for doing these evaluations. Next slide, please. But we still need to be careful because the paradox is that although 90 to 95% of those who undergo an evaluation by an allergist safely have their penicillin allergy removed, it is also true that antibiotics, mostly beta-lactams, are the leading cause of anaphylaxis in late pregnancy. So these two facts coexist and warrant caution. Next slide, please. Next case is a 21-year-old who presents at 24 weeks of gestation. And a treponemal serology, the TPPA antibody, is positive. This reflexes to the non-treponemal serology, the RPR, and that is elevated at 1 to 64. This patient recalls having had a single painless genital ulcer several months ago. This is an image of an oral ulcer. As a reminder that while we think of syphilis with genital ulcers, oral ulcers can also present with, or can also occur in primary syphilis. And both typically resolve without treatment, even as the infection continues. And this patient reports a history of penicillin allergy. And as probably most of you know, is syphilis in pregnancy, the only answer is penicillin. So, and this has become an increasing problem. Next slide, please. As after reaching historic lows in 2000 and 2001, rates of primary and secondary syphilis in the US population have increased nearly every year through 2022 and seem to be continuing in that trend. The overall rate of syphilis in mothers giving birth in the United States more than tripled from 2016 to 2022, rising from about 87 per 100,000 births to 280 per 100,000 births. So it's something we need to be on the lookout for. And the rise was particularly high among young patients, Native American patients, and quadrupled among patients who were less than age of 24. So very important to look out for. Next slide, please. And the rise was highest among Native American and Native Alaskan patients. And in that population, it increased about 8-fold over the same period of time. So, and as for many STIs, the health equity ramifications of this are really substantial. Another study that we're doing actually focuses on the equity of penicillin allergy delabeling, which hasn't been published yet, so I'm not showing the data. But there are multiple aspects of infection and allergy equity that intersect here. You can see that in California, the rate is significantly increased to 260 per 100,000 population. Next slide, please. So in pregnancy, a patient with syphilis and penicillin allergy must be referred to allergy. Congenital syphilis, as many of you know, It is associated with fetal and neonatal deaths, low birth weight, preterm labor, brain and nerve disorders. And the options are testing plus or minus a challenge to delabel, or testing and, if confirmed, to desensitize. So why not one of the alternatives, ceftriaxone, erythromycin, azithromycin, doxycycline, which we might use in somebody who's not pregnant. So ceftriaxone, erythromycin, and azithro don't cross the placental barrier completely. So if they're used, then the newborn needs to be treated again after delivery. And doxycycline, as I'm sure most of you know, should not be used in pregnancy because of the effect on bones. Next slide, please. So what is the difference between challenge and desensitization? So a challenge in our, from an allergist standpoint, is, you know, the same thing as a graded challenge or a test dose. And the purpose is to demonstrate the absence of allergy. And this is for patients who are at low risk for a true allergy. And usually is 1 to 3 steps over 1 to 2 hours. It can be done on the floor. Sometimes we do it in our clinic for oral medications. And if they pass it, then in the future, they can take it whenever they want to. They can take it ad lib. Desensitization, in contrast, is induction of temporary tolerance. So this is for patients who have a true allergy or are too high risk for a graded challenge. And this is 10 to 12 steps over 3 to 5 hours. And for antibiotics, it's typically done in the ICU with one-on-one nursing. And if it is tolerated, then in the future, any administrations of the same antibiotic, if it is now out of the system, has to be done by desensitization. So desensitization is not a cure. If somebody says, yeah, I was desensitized to the antibiotic years ago, now I can take it whenever I want to, that actually was, that person was not allergic. They essentially had a challenge, but it's not curative. Next slide, please. So penicillin allergy, the label has been associated with all kinds of untoward outcomes. So multi-drug resistant organism colonization and infection with C. diff, MRSA, VRE. C. diff in particular is an institutional priority. Surgical site infections, also an institutional priority. Treatment failures, time to death or best, healthcare utilization, including visits. Very interesting. Kaiser data has demonstrated that healthcare utilization is much higher, is significantly higher among patients with penicillin allergy labels. More days in hospital, more readmissions, antibiotic costs, duration changes, more IV antibiotic use, more non-beta-lactam use, more astranium use. And astranium is not a great antibiotic, and we use it only when we really have to, but and it's often used in people with penicillin allergy. And of course, less concordance with treatment guidelines, because treatment of most common infections is with beta-lactams as the first and best line. Next slide, please. So some people might say, well, maybe these patients are just sicker who have a penicillin allergy. Maybe they've just been in the healthcare system more, and maybe that's why you have all of these negative outcomes. But in fact, there's also been studies done on the impact of delabeling penicillin allergy. And it turns out that when patients are delabeled of their penicillin allergy, not surprisingly, there's increased use of first choice antibiotics, more use of beta-lactams, and greater treatment efficacy. But also very interestingly, and again from Kaiser and other large healthcare systems, the healthcare utilization goes down. Outpatient visits go down, hospital days go down, antibiotic expenditures also go down, and there's less use of broad spectrum antibiotics. And so for whatever reason, people go to the ED, go to the clinic, and go to the hospital less after penicillin allergies are delabeled. Next slide, please. And I alluded to this a little bit earlier. There is also great interest in inequities in penicillin allergy delabeling, as there is in a lot of areas of specialty care. And this is a schematic of some of the issues specific to penicillin allergy, which is not in and of itself a chronic health condition, but is something that, if evaluated by an allergist, can affect somebody's future health outcomes and care. A lot of electronic medical record issues around this, and issues with getting people into specialty care. Next slide, please. So now setting aside penicillin allergy and moving on to other drug allergies. This is local anesthetic allergy is, I think, particularly relevant to OB populations because of this is something that is often needed in the peripartum period of time. Most adverse reactions are non-allergic. Most of them are vasovagal or toxic or idiosyncratic. Inadvertent IV administration along with epinephrine. There is known to be cross-reactivity within groups, although not between groups. So there are the esters and the amides for those who have true allergy. And the group 1 esters include procaine, benzocaine, chlorprocaine, tetracaine, and the group 2 amides are lidocaine, bupivacaine, mepivacaine, ropivacaine, and more. Parabens may be used as preservatives, and so when we do testing and challenges, we usually try to avoid those that contain preservatives, and just to simplify. And skin testing can be done, but there is some risk of false positives and negatives, and so we usually round this out with a graded challenge, sometimes with a placebo challenge, but often we don't need to do that. Often we just do a graded challenge with subcutaneous local anesthetic. And the likelihood of being able to delabel people of a local anesthetic allergy is very high. Next slide, please. Another class of medication that's particularly relevant to the OB population, since low-dose aspirin is indicated for most pregnant patients 35 years of age and above, as well as those with any number of a host of other conditions. This is a very commonly listed allergy, but with a simple history, we can usually tell whether this person can tolerate low-dose aspirin, and if not, what kind of reaction they might have. So these are the general categories of aspirin and NSAID allergy. There is single agent IgE-mediated anaphylaxis, and this is a sort of classic anaphylaxis. You might get hives and tongue swelling, then difficulty breathing, wheezing, hypotension. But if this happens, it's typically only with a single agent, most commonly ibuprofen, could be with naproxen or naproxen. Whether this actually exists with aspirin is debatable within the allergy community. Many allergists think that this does not actually truly exist with aspirin. And that's very helpful when it comes time to try to evaluate whether somebody can take aspirin. The two other major categories are urticaria, angioedema, and which are cross-reactive among aspirin and NSAIDs. And this can be in the setting of having chronic spontaneous urticaria or chronic idiopathic urticaria. Aspirin exacerbated respiratory disease, or AERD, otherwise known as Samter's triad, is another category of aspirin and NSAID allergy. Some patients have both, which is why this Venn diagram overlaps. But that's very different. That is a respiratory reaction. And so I've definitely seen patients who have avoided aspirin and NSAIDs their whole lives, thinking that they had aspirin-induced anaphylaxis, when on more careful history, it turns out that that wheezing and bronchospasm was because of AERD. And that is something that we can actually desensitize. So we can get people to tolerate aspirin under those circumstances. So when we see patients who have aspirin and NSAID allergy, there's a good chance that we can delabel them of their aspirin allergy. Next slide, please. So next group of medications are vaccines. So I think many of you know why it's important to give vaccines during pregnancy to protect the pregnant person as well as to protect the baby. The antibodies cross the placenta, and I think that this is fairly well known. This is and I also wanted to dispel some misconceptions I've heard from patients and in the press about vaccinations in pregnancy. And on the right here, we have some of the vaccines that would be relevant to that category of concern. And very commonly we hear patients say when offered a vaccine that they just want to wait until after they deliver to get the vaccine, thinking that it's just for them, or they think that they will confer the same benefits by breastfeeding and after getting the vaccine postpartum. But really, giving the vaccine is a twofer, because we want to we can protect both the pregnant person and the infant with a single vaccine, which is really pretty amazing. IgG, so these antibodies are IgG type antibodies that cross the placenta during the second and third trimesters, particularly late second and during third, via the neonatal Fc receptor. And this receptor is not expressed the entire time in high quantity. And And antibody formation doesn't start in infants until they're about 4 to 6 months old. So they're really depending on maternal IgG antibodies that are transferred across the placenta. So, and when is it that during pregnancy should vaccines be given? So antibody formation requires about 2 weeks. Antibodies cross the placenta in later pregnancy. So you should take that into account in deciding when vaccines should be given. And that's why recommendations exist as they do for Tdap to be given later in pregnancy to boost those pertussis IgG antibodies. So we don't want to wait until right before somebody is expected to deliver. We do want to give it a little bit earlier. Giving it before the second trimester is certainly fine because those boosted antibodies will stay high for a while. And we often hear that breastfeeding might confer those antibodies, but in fact, what does breast milk do? It provides mucosal IgA antibodies, and those stay at the mucosa. They're not really absorbed, and IgG type antibodies that can be found in breast milk are really not absorbed. They're digested in the GI tract, and they don't do much at the mucosal surface. And so even though there have studies been done finding, say, SARS-CoV-2 IgG in breast milk, that does not get conferred to the infant. So that's why it is important to do the vaccination prior to delivery so that the infant can get the benefit of that. So, and which vaccines are contraindicated in pregnancy? Those are live attenuated vaccines like MMR, varicella, yellow fever. Next slide, please. So when it comes to vaccine allergy, true anaphylaxis is actually quite rare. Skin testing is pretty helpful, and so we do this in our clinic. And there are some components of vaccines to be aware of, but these are more rare. True allergies to these components and their effect on vaccinations is actually much more rare than people might think. So gelatin is in some preparations, including MMR, VZV, Japanese encephalitis, and people who have gelatin allergy might react to marshmallows, Jell-O, gummies. If they have a positive history, then we might do skin testing. And if skin testing is negative, then we would just give the vaccination normally. If it's positive, then we might do a graded challenge. This actually accounts for a lot of MMR reactions. Egg allergy is only potentially significant in yellow fever vaccine. And it's no longer an issue for influenza and MMR vaccines. Those can just be given normally. Now, casein, which is a milk protein, comes up because Tdap and DTaP are made in cow's milk-derived media, but it's very rare, but not zero, to have a severe reaction in kids with severe cow's milk allergy. But most kids, even those who have severe cow's milk allergy, don't have any reactions to these vaccinations. There are some preservatives like thimerosal that are used a lot less than they used to be. It can cause some contact dermatitis if applied topically, but it's rare for those to cause injection site reactions, even with allergic contact dermatitis. Antibiotics are sometimes components, and so we might test before, like streptomycin, before giving vaccines. Latex is mostly a theoretical risk with rubber stoppers of the vaccines, especially if it's drawn up through the stopper. But most people get the vaccines without the rubber stopper, or you can remove the stopper before drawing it up and just observe. Other topics that might come up: yeast for Hep B and HPV vaccine, very rare though to get those reactions. And dextran is no longer used in most vaccines. Next slide, please. So COVID vaccine allergy has been a hot topic, although a little less hot than it was a year or two ago. True anaphylaxis is extremely rare. And interestingly, even after immediate or other allergic type first dose reactions, the likelihood of a second dose reaction is less than 10%. Early on, when we started giving the vaccination, there was a lot of concern about vaccine-related reactions. And there were a couple of things that were reassuring. Number one, there was a large group of healthcare workers who had first dose reactions who said, I don't care if I have another reaction, I'll bring my EpiPen, I just want that second dose of the vaccine. And very few of them reacted on the second dose. So that was helpful. And then we did all the skin testing to the different components of the vaccine, and it turned out that it was not helpful. It was not predictive. And so those immediate reactions are not like peanut allergy, where, you know, every time somebody's exposed to that, they'll have that same reaction. This seems to be more of just like a non-specific inflammation. We think that it might be complement mediated when it happens, and it's usually quite treatable. The components of concern in the COVID vaccine allergy were PEG, or polyethylene glycol, and polysorbate 80. But it turns out that even testing with these has not really revealed a lot of true allergies. But people can develop allergies to PEG and polysorbate 80. I just want to point out that Novavax is a COVID vaccine that is non-mRNA for those of your patients that are reluctant to get mRNA vaccines. This is a protein subunit vaccine, and it contains polysorbate and not PEG, but polysorbate is in a lot of stuff, and it's very rare to see somebody with a true allergy to polysorbate. Next slide, please. So a few myths in drug allergy. This is a creature from Ugandan mythology with many eyes, and he's all interested in drug allergy myths. I think this artist produces some really fun and beautiful art. Next slide, please. So here's a myth that we hear a lot. If a patient previously tolerated a medication, an allergy cannot develop in the future. In fact, intermittent exposures to medications may be more sensitizing. So antibiotic allergies really were understood best in cystic fibrosis patients who were getting a lot of antibiotics, and that's how they were getting their allergies. And that's how we learned a lot about antibiotic desensitization. And this is distinct from food allergies, where, you know, if somebody has tolerated egg many times in the past, the likelihood of developing a new egg allergy is very rare. Next slide, please. Next myth to dispel: milk allergic patients should not contain medications that contain lactose. In fact, lactose is in a lot of medications, a lot of tablets, and milk allergic patients react to the proteins and not lactose. Lactose is a sugar, and these patients do not need to avoid lactose-containing medications, but should take caution with casein. So casein is in some medications. Lactose intolerance is distinct from milk allergy. So milk allergy, we're talking about reactions to the protein, whereas lactose intolerance is a condition where people don't make enough lactase, which is an enzyme that breaks down lactose. And as a result, the bacteria in their GI tract then metabolizes the lactose and produces a lot of gas, and they get gas and bloating and diarrhea. So separate from milk allergy. And people who have lactose intolerance usually are fine with lactose-containing tablets because the amount is so small. Next slide, please. Next myth: egg allergic patients should not get flu vaccines or need to be referred to allergy or need to get egg-free flu shots. So flu vaccination, some formulations are cultured on fluid from chicken embryos. But the amount of egg protein in vaccines has decreased over the years. It's really tiny. So even if a patient has a history of egg anaphylaxis, you don't need to really ask anymore. It's still on the form, I think, for the flu shot, but and previously we recommended skin testing with the flu vaccine, and then we recommend doing fractionation. But now it turns out that even people with egg anaphylaxis can get the flu shot without additional precautions. They can just get the standard one. Next slide, please. So another myth: if a patient has a shellfish allergy, iodinated contrast and or povidone iodine should be avoided. This is just a myth. There is no such cross-reactivity. Iodine is an element. Shellfish allergy is to a muscle protein called tropomyosin, and iodinated contrast and shellfish allergy really have no relationship with each other. Next slide, please. So this is the last of the myth busting. So just check my time here. The myth is to avoid sulf something if a patient is allergic to sulf something. And these are sulfates, sulfas, sulfa antibiotics, sulfa non-antibiotics, and sulfites. They all revolve around sulfur, but really there's no cross-reactivity among these groups. So sulfur, again, is an element, and it is an element in many different things. You can't develop an allergy to an element, or at least not this element. And sulfite is the name of given to a class of commonly used preservatives that reduce spoilage. They act as antioxidants. They prevent vegetable and fruit browning. They're in baked goods, condiments, shrimp, some wines, white wine more than red wine, beer, dried fruits, usually in high quantities. They used to get sprayed on salad bars, but the FDA has banned that practice and has banned having them sprayed on fresh fruits. But sulfites can cause asthma exacerbations, anaphylaxis, urticaria. And so now the FDA requires labeling of any food or beverage with greater than 10 parts per million of these preservatives. Some of the common names include like sulfur dioxide. So if you like dry mangoes, you might see this on the label. Potassium bisulfite, potassium metabisulfite, and so on. There's unfortunately, any good blood test to test for sulfite reactions. Sulfa drugs are antibiotics and other medications that contain a sulfonamide molecule, which is different from sulfites. And it turns out that sulfa antibiotics, like trimethoprim sulfamethoxazole, otherwise known as Bactrim, do not cross-react with sulfa non-antibiotics like furosemide. Sulfates are salts of sulfuric acid and are present in many medicines, supplements, and personal care products, and it just means it's like an SO4 and SO3 moiety. It's not really something that in and of itself is allergenic. This is, again, not the same thing as sulfites or sulfa drugs. Sulfur is an element that is essential for life. It's found in sulfites and on all of these things, but by itself is not an allergen. But elemental sulfur, if inhaled in a pure form, can rarely cause some respiratory issues. Next slide, please. So now onto the general allergy and pregnancy topics. So this is an issue of Immunology and Allergy Clinics of North America that has a lot of great allergy topics in covering pregnancy and allergy, including 3 chapters just on asthma, chronic management, medication safety, and equity and outcomes. Chapters on rhinitis, mastocytosis, biologics, but interesting, nothing on drug allergy. So good thing we just spent 60% of our time talking about drug allergy. Next slide, please. So anaphylaxis during pregnancy is a topic that I think many allergists worry about when it comes to doing testing in pregnant patients, and something that, as I've gotten to know some of our MFM colleagues, is not necessarily a source of concern so much in nearly as much among the OBs. The triggers in the first trimester are similar to the general population, including foods, medications, venom, stings. In the second and third trimesters, mostly drug-induced. And of the drugs triggering anaphylaxis, mostly antibiotics, and among antibiotics, mostly beta-lactams, as we discussed, and highly associated actually with cesarean deliveries, where antibiotics are being given, and many other medications, perioperative medications. The anaphylaxis in pregnancy, there's a couple things to note that's different from treatment of anaphylaxis. Otherwise, we have the patient lie down on their left side to take the pressure off the IVC. And this is probably something that you all do by second nature if you take care of these patients. And we need to be aware that there are some differences in presentation, including that they're less likely to have cutaneous symptoms, and that there might be some symptoms like low back pain and uterine cramping or vulvar and vaginal itching that are associated with anaphylaxis that would not be seen in somebody who's not pregnant. Epinephrine is still the drug of choice, and we would use the doses that are normally used for non-pregnant adults. There was recently saw a reassuring report of fetal monitoring in a patient who got epi during a penicillin desensitization, and the fetal parameters were entirely stable throughout, even despite getting epi. Patients with a known history of anaphylaxis and of allergies and possible anaphylaxis need to carry an EpiPen and have an action plan. But when it comes to anaphylaxis, the anaphylaxis treatment guidance has really shifted away from steroids, and actually, in fact, a lot away from antihistamines, because those don't do anything for acute anaphylaxis. It's really epi, IV fluids, oxygen. So next slide, please. So condensing everything about asthma and pregnancy down to this one slide. When it comes to asthma and pregnancy, the rule of thirds is that a third get better, a third get worse, and a third have stable asthma in pregnancy. But probably more like 40% get worse based on more recent data. The risks of poor asthma control are significant. It's associated with a lot of negative outcomes, including preterm labor. And these days now, let's see, preterm birth, low birth weight, preeclampsia, and severe asthma in pregnancy is a cause of mortality as well. So it's associated also with higher risk of poor mental health, including postpartum depression. And optimal asthma management is really associated with improved outcomes in maternal and fetal health. So the medications that we recommend in pregnancy are listed here with the green. So green, dark green considered safe, light green, probably safe, avoid anything in red. So for the short-acting bronchodilator, albuterol is the best studied. For inhaled steroids, we would prefer budesonide or fluticasone if starting the ICS in pregnancy. But if the patient is actually already on an ICS and is stable, we don't tend to change it. There are many options for management. These days, we're doing a lot more what we call SMART therapy. This is an acronym based on many studies of single inhaler maintenance and reliever therapy. That's what SMART stands for. And that is using a combination inhaled corticosteroid with that's formulated with a short-acting bronchodilator or a long-acting bronchodilator for as both as needed and as the maintenance inhaler instead of having two separate inhalers. So in short, the rescue and the maintenance inhaler are one. It has not really been studied in this particular setting, but it is becoming more and more common that we're doing this in adults. The FDA has yet to catch up on this, so that it can be hard to get medications approved on that basis. Biologics. So the one biologic that I use routinely and in pregnancy is omalizumab. It's an anti-IgE monoclonal antibody, and is quite effective for asthma, particularly in the young people. So we have all of these different options. Really, the control of asthma is not limited by the number of medications we have. It's limited more by getting these medications to our patients. So the last case is a pregnant patient who works full-time, has 3 kids, partner recently lost his job, history of food insecurity, lives an hour away from our clinic, has moderate persistent asthma since childhood, asthma symptoms almost daily, nighttime symptoms twice weekly, uses albuterol daily, frequently takes oral prednisone. Next slide, please. Very badly controlled asthma. Fluticasone inhaler is often out of stock at her pharmacy. She didn't like montelukast, which is singular. Next slide, please. Often cancels her appointments because of no-shows, because of work and childcare. And so we're unable to do spirometry and pheno. We've recommended budesonide formoterol at the high dose, and she notes some moderate benefit, but requests more prednisone, which is usually a sign that things are not going well. We've recommended omalizumab, but she's unable to do the first 3 injection visits in clinic, which is part of the required observation period. And as a result, asthma remains poorly controlled and continues to take a lot of prednisone during pregnancy. So a lot of opportunities for room for improvement with regard to asthma equity. Next slide, please. So rhinitis in pregnancy is its own entity. There's a lot of conflicting data on whether it's caused by progesterone-induced vasodilation. For the sake of time, I'll skip over this, but you have the slides. But I would just say avoid Afrin and topical nasal decongestants. And this tends to resolve after delivery. Next slide, please. Allergic skin disorders in pregnancy. I will also skip over just so we can talk about food allergy, which I know is a topic of great interest. Next slide, please. So, and I'm popping this into the talk, even though I know it's about infant food allergy, because it comes up in most of the visits I have with pregnant patients who are seeing us for drug allergy. They often want to know, what can they do to prevent infant drug allergy? So this is distinct from secondary and tertiary prevention, which come after the disease or the allergy has developed, like peanut allergy and milk protein allergy. This just refers to the prevention of the development of allergy. So allergenic foods, milk, wheat, egg, soy, peanut, tree nuts, sesame, fish, shellfish. There is no apparent role for maternal avoidance in diet, avoidance diet in pregnancy and breastfeeding. So lots of data, variable quality has sort of converged on this not being, and so when we have patients who say, oh, I shouldn't have eaten all that peanut butter during pregnancy, it doesn't seem to actually affect what happens with the kids. But what we do recommend, and I don't have time to get into all the data, but is early introduction of allergenic foods in infancy, especially in those kids who have a high risk of food allergy on the basis of family history or who have eczema. Also that, and so in the 4 to 6 month period, we'd like babies to start being exposed to these. And that is what seems to will help us to prevent a lot of infant food allergy. We also recommend avoiding topical introduction, meaning topical application of foods, unless the baby is already eating that food. And this might sound odd to those who don't do it, but we have a lot of patients who say, oh, this is a natural thing. This is a natural thing for this kid's eczema. We're going to apply this milk containing solution or this chickpea flour or this chickpea paste or oatmeal, nut oils, etc. And that actually is a setup for sensitizing the baby to these foods. So that is all my slides. Thank you so much. Next slide, please, for attending. And I'm happy to take questions if we have any time.
Thank you so much, Dr. Liu. That was wonderful. I know I definitely learned a lot. We do have a couple of questions here. Let me just open our chat for us real quick, and I will see if we can get to those. Let me see. I'm gonna stop sharing real quick. I do just want to follow up with a quick question that we had. It was relevant to the last couple slides that you were just sharing. If you can just confirm with us that if mom has an allergy, whether it's a milk allergy, a food allergy, that there are no additional guidance needed for if baby needs to be taking formula versus breastfeeding versus using a sort of soy-based formula as well. I know I've heard a lot of mixed reviews in my own experience in hospital settings, but would love to just get that from the source.
Yeah. So just to clarify, so the mom has the milk allergy and what to do for baby. There's not really any guidance that baby has to eat anything differently. And in fact, I would encourage parents of if a parent has a milk allergy and is worried about the child having the milk allergy, I would recommend actually earlier introduction. So in the 4 to 6 month age range, some sort of milk, not necessarily a glass of cow's milk, but some sort of cow's milk containing foods. And that might be in the form of yogurt or heated or cooked milk, which is less allergenic than straight milk.
Mm-hmm. Along the same lines, with a similar question, if mom has a penicillin allergy, does that make a difference on whether or not baby can get penicillin?
It turns out that it doesn't. And so that is actually a pretty common reason that people avoid penicillins, that they have been told, oh, my dad had penicillin allergy, so I was told to avoid penicillin allergy. And we don't recommend that.
We have some questions in the chat. I'll go with our first one. Is allergy testing during pregnancy usually covered by insurance, especially for Medi-Cal patients, if you're aware or not? Be a nice thing to discuss in the conversation as we introduce allergies in that conversation with pregnancy.
So the testing that we do in pregnancy is usually limited to what we think will make a difference during pregnancy. So we wouldn't on a routine basis do environmental testing, so aeroallergen testing, skin testing at least in pregnancy, because there's an incredibly tiny chance that somebody could react to that. And why would you do that if it's not going to benefit the patient during pregnancy? But we can do blood testing. So we can do serologic testing. We can draw a vial of blood and look to see if they have aeroallergens or food allergies and go from there. So there are a lot of other options. But we would do penicillin testing because it affects the care of the patient during pregnancy.
Mm-hmm. Another question here. Are there any intricacies with drug-induced anaphylaxis in pregnancy? It occasionally occurs in the OR during surgery, but what about out in the community, even during transport to a hospital? Any things that we need to know?
So when anaphylaxis occurs outside the hospital, hopefully that you would want to get the patient epi as soon as possible, including if they're pregnant. And so you got to save the patient to save the baby. And epi is the most effective medication in anaphylaxis. So and sometimes, you know, I think that EMTs that we've encountered have had sort of variable training on that and have had variable updating on using epi over Benadryl in somebody who's having true anaphylaxis. I don't know if that answered your question, but you know, the main thing is to try to get them epi ASAP.
And we have some theme in the questions about really around this education need for allergies. I know for me specifically, the myth versus fact on allergies for shellfish and iodine, that was always something I was taught in the hospital setting, to not introduce that to patients with shellfish allergies. What can you speak to about the move towards education to staff members, to OR techs, to, you know, people that we work with who are perpetuating some of these myths and stereotypes, or educating around some of these things?
Yeah. So it's actually still in the EMR. And so the allergy section of the EMR will still flag all of that. And so there's a lot that needs to be done there. And so in the drug allergy community, you know, there's a lot of discussion of how do you, because I think a lot of our education comes from the EMR and what flags, and that perpetuates these myths. How do we change the EMR allergy section in EPIC so that these myths are not perpetuated? So, but you know, as you might imagine, changing anything in EPIC is a pretty big lift, but there's a lot of move toward doing that as a way of educating people and taking out some of this low-hanging fruit. We know that it's a myth.
Mm-hmm. Case Moley has asked, or has brought up a comment that your talk seems to make a really strong argument to make delabeling of penicillin a standard of care for all adults, but particularly for pregnant people and others in medically higher risk categories. Can you speak to any move towards that?
So a lot of the penicillin allergy delabeling literature has been in lower risk populations. One of my main interests is in antibiotic allergy in high risk populations. So pregnant, transplant, oncology patients, people who have other high risk medical conditions, because I think that our impact is potentially greater in patients who often need antibiotics. So, but I think that there's a lot of risk aversion that will just have to really slowly change. And I think that if our referring services ask for it, then ask it of their local allergists, then there may be a greater, we can grow that interest and grow the comfort among our community colleagues in managing and delabeling antibiotic allergies in high-risk patients.
Another question about the age recommendations to introduce infants to certain foods, and if you have any insight into why we might be feeling like we're seeing certain allergies with like peanut butter or peanuts more often now than maybe we may have seen in the past.
That's a great question and a whole other topic. I'll try to consolidate it if I can. So about 20 years ago, you know, people didn't know why food allergies were increasing. So they said, you know, started to recommend, the AAP started to recommend, well, let's wait until their immune systems are a little bit more mature, and then introduce these foods one by one. And so then there was all this, that there were these, you know, guidelines that many people here probably know about. They said, you know, no, wheat at age 9 months, you know, egg, you know, 9 to 12 months, milk at age 12 months, and, you know, peanuts, tree nuts, age 18 months to 3 years, you know, all this delayed introduction. And food allergies kept going up and up. Around the same time, there was a lot of epidemiologic evidence in animal studies showing that delayed introduction and introduction through the skin before ingestion of the food seemed to be related to sensitization and allergy. And then there was this big study called the LEAP study that caused a sea change in how we practice food allergy. And in that study, babies 4 to 11 months old at high risk of developing food allergies were skin tested, and if they have a negative or a small positive skin test, were randomly assigned to either eat or avoid peanut. And those who ate a small amount of peanut, despite a small positive skin test or a negative skin test to begin with, almost none of them had peanut allergy at the age of 5 when they were all challenged to a large amount. And those who avoided it up until the age of 5, even if they started out with a negative skin test, so not even sensitized, there were 12% developed a peanut allergy during that time. And if they had a small positive skin test as infants and then avoided peanut at age 5, over 35% had a true peanut allergy. So the bottom line is that all of this delayed introduction seems to have made the problem worse. And so now the recommendation is to do early introduction. I hope that kind of gives you.
Yeah, I think so. It's
idea.
a very interesting thought to be considering. Another question just popped in. My population is very high risk pregnant women with an overwhelming syphilis population. What's the best way to get testing done? Medi-Cal does cover allergy testing, but most concerned with penicillin issues.
So we work with a lot of different practices to see patients who, and this is something that I'm, feel really passionately about, that pregnant patients with syphilis need to get the best care and get penicillin. So, we are happy to take referrals. We take urgent referrals. We will work with you to take care of these patients. It is logistically really complicated because ideally they are in a hospital to get penicillin desensitization. And so that might also require establishing some partnerships with your local hospital, since we don't have admitting privileges everywhere.
That's interesting. There's been a few questions sort of related to breastfeeding and mom's diet and how that develops may have an impact on babies' allergies or potential for allergies, as well as moms who intake dairy products and or maybe don't take in dairy products and proper nutrition for baby as well.
So we think that the diet of the breastfeeding parent does not affect the infant's allergies. However, there's a couple of caveats to this. One is that if say, the household ingestion of a food before an infant is eating that food seems to increase the risk of developing an allergy to that, probably because, say, for example, mom or siblings eat peanut butter, they get it on their mouth, they go over and they pick up the baby who's all eczematous and has this inflamed eczematous skin, they kiss the baby's never eaten peanut butter before, and so that peanut butter gets stuck to their skin and is then presented to all this inflamed skin, and that seems to increase the risk of peanut sensitization. So it's not because it's in the breast milk, but it's just it's around. So that's a caveat. So if it's in the diet of the new mom, then it's not so much because of the breast milk, but just that it's in the environment. So that's one thing to be aware of. And then the other is that this is distinct. Milk allergy and milk protein allergy are distinct. And so the names are terrible. So milk protein allergy is a different kind of reaction. That is where, babies are having bloody stool and, sometimes vomiting and diarrhea when there's milk in breastfeeding mom's diet, or any kind of dairy ingestion. In contrast to milk allergy, which is when the baby eats something that has milk, has hives, anaphylaxis, difficulty breathing, wheezing, etc. The confusing part is that milk allergy is also to the protein. And so when we say milk protein allergy, it's just a bad name because both of them are to the protein, but they're very distinct types of reactions. And so that is something where the diet of the breastfeeding parent might affect what's going on with the baby, but that is a different kind of allergy. So the milk protein allergy is it's the kind where, usually they say, okay, let's just avoid it for now. And when the baby's a year old, we'll try it again and see what happens. But that's different from milk allergy.
Great. Thank you so much. Thank you, Dr. Liu, for your amazing talk. This was so informative. Thank you, everyone, for your questions.